Today we are going to learn something about a condition of the eye called keratoconus and how their vision can be maximized by using the RGP contact lenses. Keratoconus is a degenerative corneal condition in which there is progressive thinning of the cornea, and eventually there's a protrusion or called the apex of the cone, which is usually inferior and laterally. And these patients come with high myopia as well as high astigmatism, and as a result they are unable to see well. Here you can see the picture and how there is coning of the cornea. It is progressive thinning and weakening of the cornea, and the normal thickness of the eye is 400 to 600, but usually in the keratoconus patient, it is less than 400 by the time they come and see the ophthalmologist. There's progressive steepness as well, and when they come, usually the K readings or keratometric readings will be around 46 diopters and above, and can even go as steep as 72. Usually it starts as a condition in the eye when the patients are in their teens, and it continues till their mid-30s. This is just to show you the clear cornea, but steep. The clinical appearance can be almost normal. Like in this eye, it is less deep at the slit lamp view, and the left eye, which is more than 49 diopters. Clinical appearance may appear normal, and the patient just complains of progressive poor vision over a few years, not correctable with spectacles or frequent change of glasses, seen by several ophthalmologists already, and often mistaken that they have one eye which is blunted vision or amblyopic. Keratoconus patients can look normal, like this patient, more in males than females, and quite often associated with allergic nose, skin, or other condition. The normal appearance in presenting the visual acuity in this patient, on the right eye, he came with counting fingers, on the left eye, 6/24. And the final vision after cross-linking treatment and RGP was 6/12 partial and 6/9 on the left. The demographic data of the ethnicity in Malaysia shows a high incidence for Indians in the ratio of 6:3:1. The early signs of keratoconus on slit lamp microscopy may just be revealing a few Vaux lines, breaks in the Descemet's membrane, and the fluorescein stain shows only superficial punctate keratitis. When we take a topography, the placidus disc reflection on the cornea is irregular, as wherever there is steepness, the rings are closer to each other, indicating steepness. Topography is very important in the diagnosis of keratoconus, and it is easy with a topogram for diagnostic confirmation. Early stages can present as high myopic astigmatism, form first keratoconus where it stops. Usually the keratometric reading is above 46 diopters, and you can even see it as a teardrop sign. The K readings on the topogram can, in the normal patients, will show normal with the rule astigmatism. And this symmetrical with against the rule astigmatism will be in this way. In the keratoconus patient, the topogram is typically a very steep cornea apex of the cone being inferior and either lateral or medial. The topogram confirms the keratoconus, and this is a gross keratoconus where the topogram shows the typical inferiorly situated apex of the cone in both the eyes. Confirmation is by topography mainly. And the role of RGP contact lenses is very important in stabilization of the progressive corneal steepening. There is a corneal shaping and regularization effect after cross-linking. And the apex of the cone also moves to the center of the cone, of the cornea. Visual rehabilitation with RGP or rigid gas permeable contact lenses, which are smaller than the cornea. These are polymethacrylate, they are hard or semi-hard, and differs from the soft contact lens because forces, in a way, the soft corneal curvature to bend to its shape, and therefore there is corneal shaping or regularization. The RGPs usually fit. The cone apex is very steep, and the RGP contact lens sits precariously on the cornea, as in the right. It is situated a bit inferiorly. The RGPs, which are low riding, will show a central pooling of fluorescein and indicates that the lens is too steep. The RGPs don't always fit well, and the patient needs to be educated and counseled as to learn to blink gently, use tears natural freely and regularly. If there's a loose fit, the keratoconus lens fit usually results because of the irregularity of the cornea and very steep keratometric readings. After the cross-linking treatment, the lenses become better centered, and as the apex of the cone also changes to a more central position. The disadvantage of the REP is difficult to fit. It demands cooperation of the patient, and the patient's patience is required to acquire maximum effect. The advantages are the maximum visual potential, little or no complications from infection, and is easier to maintain. Visual rehabilitation with keratoconus RGPs can show a very good fit. The RGP is almost ideal because of central thinning meniscus of tears and pooling centrally. Gross keratoconus with acute hydrops shows what is called the Munson sign, and you have an inferior coning of the lower lid due to the coning of the apex of the cornea. And there is also a decimetocele and gross corneal edema, as is seen here as well on the side view. The final visual outcome needs penetrating keratoplasty sometimes, and the corneal scar, if it is right in the center, as in this case, will justify doing a PK. The very thin cornea with variable thickness is seen. Penetrating keratoplasty is the treatment that can be done. And cross-linking is the new international nomenclature instead of UVC3R for corneal cross-linking, as was confirmed at the third international cross-linking experts meeting in Zurich in 2007. This is to show you the machine which highlights the keratoconus treatment. Cross-linking works because in cross-linking, the collagen fibers become organized. And here we have an initial pilot study of about 10 patients in which after 12 months, the vision was improved tremendously. Cross-linking treatment of keratoconus, if you compare the visual impairment, shows that there is very good vision. And here we just show that the number of males to female is almost 2 to 1. The ideal RGP fit after cross-linking treatment is shown here, and the central cornea touch with peripheral fluorescein. Untreated eye in the right eye shows high astigmatism and is increased, whereas in the treated eye, the coning has become narrowed and points towards the central part of the cornea. In this case, steepness of cone is reduced and the apex of the cone is more central. Or is the orthokeratology, which is to stop myopia. Contact lenses have similar principles for that of keratoconus cases. It, however, differs in that it is worn at night and there's limited application in terms of range of myopia which is treatable. The other treatment for keratoconus are intact rings. It is successful in visual recovery for some time, and eventually the weakening of the cornea due to the natural process may overcome this. In conclusion, safety and efficacy of RGP contact lens has been proven in this study over the last 2 years. The permanence of cross-linking treatment has been proven by Professor Spohr's work in Germany. And in combination with RGP, it serves to be an almost perfect combination for visual recovery for the patient with keratoconus. In conclusion, the eyes do not see what the mind does not know. Thank you.